All right. So we're looking at the arteries and arterioles, those specific branches of the vascular system, and we'll be making comparisons to the other branches that we'll talk about later on. What are their unique features? What are their unique properties, etc. So our second objective here to understand the structure and function of each of the various types of blood vessels. So this is really an overview. We want to begin by defining an artery. Remember, arteries carry blood away from the heart, not always carrying well oxygenated or poorly oxygenated blood. Okay, that's not the best way to define an artery, but its direction in terms of blood flow to or away from the heart is the best definition. So arteries always away from the heart, veins always toward the heart. We also have branches of the microcirculation, such as arterioles. They're slightly smaller arteries. Um, this is where we're going to find a lot of resistance, modification, or regulation of the arteriole size is really important in shunting blood towards or away from certain vascular beds. And then capillaries are the site of exchange. Capillaries are going to be very, very thin. They have a thin wall and allow for permeability. So exchange of materials, particles across that wall in order for perfusion at the capillary bed. And then venules on the other end are very similar to capillaries. They also have a thin wall and a small amount of smooth muscle. But in terms of their exchange, they can also have that permeability the way we see with capillaries. Finally, veins are much larger in terms of other areas of the vasculature, and specifically their lumen, okay? So as we compare the different branches here, arteries have a thick wall and a relatively small lumen, which means that the blood in this part of the vasculature is going to be under very high pressure. A lot of pressure being created by the thick middle smooth muscle layer, sometimes called the tunica media, and then a smaller lumen. Arterioles are smaller in their size overall, very muscular. So they're going to have a muscular wall that can be well innervated in terms of regulating the size and diameter. So again, the area of the vasculature where we have regulation and where we can shunt blood to and from depending on many factors, which we'll talk about. So it's the most regulated part of the vasculature and well innervated. Capillaries for exchange, thin wall, not much else, just a layer of endothelial cells and a layer of connective tissue. And then venules, very similar, slightly larger and a bit more smooth muscle than capillaries. Finally, veins. And veins you want to think about as being large, but their lumen being large, their wall being relatively thin. Okay, very thin wall as compared to arteries. But overall, we can see the size of these two vessels are similar. Veins having more volume inside, so larger lumen, and arteries having more pressure, so thicker wall, smaller lumen. Veins are also much more distendable. We'll talk about compliance in a bit. So they can, obey, they can distend. A lot of compliance with veins because of their thin wall. Okay, let's look at the vasculature and think about the layers that make up these vessels, the walls that make up the vessel. So there's going to be an endothelial layer, which is a small lining of cells that basically stack against each other. There's also going to be smooth muscle in the middle layer. Again, this is called the tunica intima, or media, excuse me, in some cases, tunica media. It's thicker, it's going to have smooth muscle. And then in the outer wall, we're going to find fibrous connective tissue, which usually makes the tunica adventitia, the outer connective tissue layer. So we're going to find this in most vessels. Again, the exception being capillaries. Capillaries don't have much else other than that small basement membrane, which is their connective tissue, and a layer of endothelial cells inside. So no media, no smooth muscle. They're simply the conduit, and they are capable of exchange, so permeability. And then elastic connective tissue is also going to be seen. This is going to be more evident in large elastic arteries like our aorta. And we're going to see that that is what creates more of the recoil that we see with the large elastic arteries, that ability to recoil, and less compliance with arteries as opposed to more compliance with veins. Okay. And then just reminding ourselves of the direction of flow. Arteries always going away from the heart. Here we're mentioning oxygenated blood because most arteries do in fact have oxygenated blood, but not all arteries. And then veins back towards the heart and deoxygenated. So most veins will have deoxygenated, but not all veins. Another feature with veins we'll talk about later on are the valves. Valves are only seen in veins, and this is really important to move them or move the blood against gravity, especially in the lower extremities. All right, so just comparing the various structures of the wall for arteries and veins. Now, moving more closely to look at arteries. Large diameter, very little resistance. Remember, arteries are leaving the heart itself. So this is too early to encounter resistance. We want this flow to be, high pressure, moving away from the ventricle and moving out towards the peripheral vasculature. So very little resistance encountered in the large arteries. The walls are going to contain elastic and fibrous connective tissue, which is what allows that blood to be moving under such high pressure, also because of the size of the lumen. And then as we move away from large arteries and we move toward smaller, more muscular arteries, these are arteries like the radial artery, the brachial artery, not as large as your central arteries like your aorta, but not as small as your tiny arterial branches. So these have a diameter less than 0.1 millimeter. They have much less elastin, so they're not as recoilable or, collapsible. And then they have a smaller radius that can be regulated via the nervous system, right? So the smooth muscle in the radius of our muscular arteries is where we have regulation to modify the size. Another thing to recall, actually, I think we discussed this earlier, is the pressure reservoir. Remember, arteries can hold pressure, they can store pressure in their walls. That's a part of the importance of the elastic fibers in their artery walls. So during a systole, when the aortic valve is open, blood is leaving the left ventricle, moving out into the aorta. And so as that blood under high pressure passes through the artery, it's going to expand the arterial wall with all that elastic fiber. So now it captures that stored pressure. And then during diastole, when the aortic valve is closed, the ventricle is filling, blood is not leaving the artery, but now we can continue maintaining that force, that flow, because we simply recoil the elastic artery and, release that stored pressure in the wall. So this is what keeps flow towards our systemic organs the same throughout both phases of the cardiac cycle. So it's similar flow in systole and then similar flow in diastole, even while the aortic valve is closed. Okay. So arteries are very important as a pressure reservoir. If we think about compliance of arteries, this is basically how responsive, how obedient the vessel is in terms of change of volume. Arteries are going to be low compliance. Okay, so very small increases in blood volume can cause large increases in pressure. If we increase the amount of blood flowing in an artery, even a small bit, we're going to increase the pressure moving through those vessels. So low compliance. Veins, on the other hand, have very high compliance. We need large volume changes in order for them to see large pressure changes. So very high in their compliance, very obedient, very responsive in terms of their change. And then thinking about how the pressure changes throughout the cardiac cycle. So some of the elements of our blood pressure reading, systolic blood pressure is the highest reading maximum pressure in the aorta, well, in our vasculature system overall, due to the ejection force during systole. So as that blood leaves the ventricle into the aorta under very high pressure. That maximum pressure reading is our systolic blood pressure. And then diastolic blood pressure is going to be the lowest, so the minimum pressure. Um, and so it's not going to be zero. We're still going to have some of that recoil allowing blood to move, which we talked about earlier, even during diastole when the aortic valve closes. So it will never go completely to zero, but it's going to be lower than the maximum pressure when blood is leaving during systole. So this is what makes up our blood pressure reading, right? When you go to the physician's office, you take a blood pressure reading, they put the cuff on, they detect your pulse, and they're basically looking for these two numbers to give you your full blood pressure reading. So a very important number to tell us about the vasculature system and to tell us about our, overall cardiac health as well. So let's talk about how we make that reading, how we get that blood pressure reading. So we need a blood pressure cuff, that's what goes around your arm, as well as the sphygmomanometer, right? This is the reading that tells you basically when the pressures are high or low, along with listening, auscultating for the blood movement sounds, right? So you also want to be listening with your stethoscope to basically see or basically listen to when you hear the turbulent blood flow go on and off. So you're going to compress the artery, usually the brachial artery. We do this at the antecubital region. We compress the brachial artery as it passes through the arm, and then we can listen for the breath sounds coming through at the cubital fossa. Now, when we hear turbulent blood flow, this is called Korsakoff sound. So we're going to listen for that turbulent blood flow, and that's going to indicate our highest reading, which is our systolic pressure. All right. And that basically means we have compressed the artery. And now, as we release the blood pressure cuff, there's a point where we're no longer completely shutting off blood flow, but we are beginning to hear some blood moving through the vessel, but it's very turbulent blood flow. So that is our highest reading or systolic. And then later, we continue to decompress that artery and we listen for laminar flow. Whenever we no longer hear that turbulent flow, we now hear a smooth flow that will indicate our lowest reading, which is our diastolic blood pressure. So basically, we listen for the turbulence. The first indicator of turbulence is systolic, and then we listen for smooth laminar flow, and the first indicator of that is diastolic, okay? And that's how we get our two numbers, by looking at the I'm gonna not pronounce this word. We look at that reading, and that will tell us our highest and lowest, which is the blood pressure, okay? All right, so looking at this visually, just to illustrate what this looks like. So first thing, we apply the blood pressure cuff. Again, this is going for the brachial artery before it divides into radial and ulnar. And we increase the cuff or inflate the cuff to where the pressure is above 110 millimeters of mercury, right? And looking at our readings here, this is basically the pressure in the vessel, that's what we're looking for, and the pressure in the cuff, okay? So we start at about 110, and we should hear no flow. This should be enough pressure to constrict your brachial artery. Now, if you have much higher blood pressures, let's say your blood pressure is 150 or 180, you're going to need to elevate your blood pressure cuff higher than 110. So you're going to need to apply more pressure than what is in the vessel in order to completely occlude the vessel and have no sound. Okay, so you may have to go higher in patients who have higher blood pressures. Then we listen for that turbulence. When we first hear the turbulence, that is the beginning of our systolic blood pressure. We can begin to hear blood moving through the vessel again. This is our Korsakoff sounds, which is turbulent flow, because blood is moving against a constricted wall. All right? And we can hear that turbulence. Now we're going to continue deflating our cuff even further, and we're going to keep listening for absolutely no sound, right? Laminar flow. And the first indicator of laminar flow, when that turbulence disappears, is our diastolic blood pressure. Now there's no compression against the artery, and so that tells us the lowest pressure needed to completely allow for laminar flow, right? And so those two numbers give us our blood pressure reading, and then our blood pressure reading can be used in other ways as well. Now, let's say it's about 110 over 70, which is kind of standard, kind of normal. Blood pressure readings can go all the way up to about 140 or so and still be within moderate range, 140 over 90 or so, while 130 over 80, 120 over 80 is more kind of standard healthy blood pressure, right? But let's say the example here, 110 over 70, 110 being our systolic, 70 being our diastolic, we can actually use that in order to determine our pulse pressure. So pulse pressure is your systolic pressure minus your diastolic pressure. So that 110 minus 70 would give us a pulse pressure of 40 millimeters of mercury, right? Another thing that we can calculate with our systolic and diastolic pressures is our mean arterial pressure, right? Our systolic pressure plus 2 times the diastolic pressure divided by 3, okay? So that will give us our mean arterial pressure, which we mentioned is very important in terms of our overall, um, vascular performance in terms of the pressure coming from the ventricle. So 110 plus 140, which is 2 times our diastolic divided by 3, and that should give you about 83.3 millimeters of mercury. So two different variables that we can calculate, or two different values that we can calculate using the systolic and diastolic.